Welcome to a new IPOPI webinar on calculated globulins. Thank you all for joining this session and taking the chance to learn about this interesting topic. I am Martine Pergent, IPOPI President, and it is my pleasure to moderate this webinar. And I would like to thank CSL Behring for making this webinar possible. Today, we will explore calculated globulins as a screening test for antibody deficiencies. To elaborate on this topic, we have a great specialist with us, Professor Stephen Jolles, consistent clinical immunologist at the University Hospital of Wales, United Kingdom. Welcome, Professor Jolles.
Thank you.
So, how will this webinar work? Professor Jolles will soon begin his presentation. When he presents, you can post your questions in the screening tab on the right side of your webinar screen. After the presentation, we will discuss a selection of the questions with Professor Jolles and with Dr. Virgil Dalm, who is working at internist clinical immunologist in the Primary Immunodeficiency Center at Erasmus Medical Center in Rotterdam, the Netherlands. He will also help answer your question in a written form. So thank you, Dr. Dalm, for kindly joining me. But now, let's get started. Professor Jolles, the floor is yours.
Thank you so much. It's a great pleasure to be invited to speak on the webinar today, all the way from Wales, and I see a truly international audience today. My topic today is going to be about a new way of screening for antibody deficiency, and that's both primary and secondary antibody deficiency using something called calculated globulins. And these are my disclosures. And over the next, say, 20 minutes or so, I'd like to walk you through what those actually are, why we would screen for antibody deficiency at all, and go through some of the underpinning work behind this so that you can see that, and then also some of the subsequent validation studies, and then talk through a case presentation and look at how we've extended the use of this very straightforward technique, and then wrap up. So I don't know if you'd recognize what's in this picture, but it struck me that it's a little bit what we're trying to do with calculated globulins is kind of look into the distance to see if we can pick these cases of antibody deficiency up early. And the picture on the screen at the moment is actually from the 1920s and 30s, and these are acoustic parabolic mirrors, and what they were trying to do was listen for planes coming across the sea to the UK, and the mirrors focused on a microphone so that they could get an early warning, if you like, of an attack. And essentially calculated globulins were also trying to get an early warning of antibody deficiency before problems can arise. So why screen at all? Well, I think antibody deficiency, in fact, is the largest group of within primary immunodeficiencies, and there remains a significant diagnostic delay. So depending on which study that you look at, it varies, but it's in the range often of years. The other reason is that the majority, and I would include in the majority the diagnostic category of common variable immunodeficiency, or CVID, is not present from birth. So we have some wonderful screening which is extending across more and more of the world for severe combined immune deficiency at birth. And of course, if the antibody deficiency is not present at birth, utilizing that technology, for example, with CREX rather than TREX to look for antibody deficiency would not necessarily pick up CVID. I think the other really important thing is that, in fact, around the world, the vast majority of primary antibody deficiency, indeed primary immunodeficiency, remains undiagnosed, and that's up to 90% in some parts of the world. And considering secondary antibody is even larger than primary antibody deficiency. But if one looks at the WHO criteria for screening, one of the reasons to screen is the fact that you can actually do something about it. And certainly, if we know about antibody deficiency, there are numerous things that we could potentially do to help. So this is a snapshot of the ESID, European Society for Immune Deficiencies database, and the categories within that of primary immune deficiencies. And first of all, I wanted just to show you that the blue, dark blue, of category of predominantly antibody disorders is really the biggest category there. But not only that, if one looks at some of the other conditions, the other slices of this pie chart, for example, predominantly T-cell deficiencies, if we look at those, in fact, although they are predominantly T-cell, they also have knock-on effects on antibodies in some of them. Other well-defined immunodeficiencies may also have antibody problems tucked in amongst that category, as would dysregulation syndromes, as would indeed autoinflammatory syndromes and unclassified. So even if you took just the blue, I think you would need to add to that. So that might be 56%, but that might take it up to an even greater percentage where one might be helped by finding an antibody problem earlier rather than later. So antibody deficiency is large in terms of primary immune deficiency. But in fact, secondary antibody deficiency is even bigger than primary antibody deficiency, and maybe 20 to 30-fold larger, it's estimated. And that's partly because, as you can see from this slide, we have got very, very clever at hitting the B cell. And these cells, as you can see on the slide, through their maturation pathway, have on their surface a number of targets. The best known of which is perhaps rituximab, which is a monoclonal antibody that kills B cells. But we've got so good at this in treating, for example, malignancies, hematological malignancies, but also autoimmune and inflammatory disease, that while we can help those diseases, and the more we do, the more impact we may have in terms of creating antibody deficiency, while at the same time, of course, helping the primary disease. So there are growth areas in secondary, but also in primary in terms of new diseases and better diagnosis. So what is calculated globulin? Well, it's in fact not rocket science. It's really, really straightforward. And CG, or calculated globulin, is actually total protein minus albumin. And total protein is usually part of what's called an LFT, or liver function test profile, in a biochemistry screen. And it's a screen that's carried out many, many, many times. So we estimated in Wales that there were about 2 million screens done per year, and that's a population of just over 3 million. So if one then looks at, and I'm following a theme here with the periscope, trying to look ahead for danger on this submarine. So the highs and the lows of calculated globulin. Well, we're, I guess, predominantly interested in the lows, and hitherto there has not been a cutoff established for the lower end of the range of calculated globulin. It used to be just used in terms of if it was very high, did someone have, for example, a myeloma because they had a paraprotein. But on the low side, if we were able to generate a cutoff, we might be able to find, for example, primary antibody deficiency such as CVID, secondary antibody deficiency, and also, of course, when you have a small paraprotein, a small monoclonal band associated with immunoparesis, which is perhaps even more common than myeloma itself, you would then have a low calculated globulin. The other thing I think it's important to note is that, in fact, as you measure total protein minus albumin, acute things like having surgery, a lot of IV fluids, being on intensive care, can shift those. So one does need to be aware that there may be some transient changes possible just because someone has been very unwell or had fluid in a hospital setting. The high levels, there's a whole range of things that essentially fit in with things that can make your immunoglobulins, your antibodies, go very high. So yes, for myeloma, MGUS, but also infections like hepatitis, HIV, and then sarcoid, connective tissue disease, and chronic infections can do that as well. So it's a very potentially rich set of information that one can get from such a simple component of liver function tests. How clearly can we see immunoglobulin when we look for it using calculated globulin? So here is an electrophoretogram where you can see to the right-hand side of that strip, there's a gamma region, and that almost looks like a bit of a smear at the end. That's the region that contains antibodies, and the main antibody within that region, antibody class, is IgG. So as you can see from the HMS calculated globulin submarine, what it's trying to do is see the IgG in amongst all of these other proteins. And on the left-hand side, and I'm sorry that I can see my pointer, but I don't think you can, is albumin. And that is the biggest protein, the biggest in terms of amount. And if you subtract that away from all the others, you will then get a snapshot onto IgG, accepting that there are these other proteins there as well. So it is a snapshot rather than a perfect measurement. So we started in Wales, and Wales is a small country on the west of the UK, and we're in this little green bit down at the bottom in Cardiff. But the question for us was, because the immunology department for Wales, immunodeficiency, is centered in Cardiff, in that little green area at the bottom. But we wanted to be able to reach out to screen across the entire country, even where there were no immunologists, for example. And so we started this project knowing that we had 3 or 4 million people, but 6 to 8 million sheep, a love of rugby, a passion for music, a beautiful coastline, and more castles than anywhere on earth. And Cardiff, the Immune Deficiency Centre for Wales, was right at the bottom. So we utilised the 13 biochemistry labs that are spread across Wales to try to look to see if we could find a way to use calculated globulin to find antibody deficiency. And the first thing we did was ask the labs across Wales to send us anonymous samples of low calculated globulin levels from their lab. So we looked at, say, a level of 15 grams per litre, and then moving across the graph, 16, 17, 18, 19, 20, going up. And then we compared that calculated globulin with our normal laboratory IgG level. And you can see the red line gives you a nice relationship with a spread of values, but a nice correlation. And if I would help you with the pointer, but I'm going to have to let you use your imaginations here. If you go from a level of, on the left, say 6 grams per liter, which would, for immunoglobulin, which is the lower limit of our cutoff, and draw an imaginary line across to the red line, and then drop it down, you reach a value of about 18 in terms of calculated globulin, and that was the cutoff that then we introduced. And so we asked the labs across Wales, before we introduced the cutoff, what do you do at the upper and lower end of your reference ranges? And looking just at the right-hand side, the lower end, the majority of laboratories actually did nothing, or they flagged it, which sort of means like nothing, or they didn't report it, which also means nothing, or they reviewed it, which also doesn't necessarily mean a diagnosis. So there was a real, we thought, opportunity to try to help and improve what happened at the lower end of the normal range once we had established a cutoff value for the laboratories. And so this is what happened when we used the cutoff value of 18. And we did, I think, about 600 to 800 samples. And you can see that if you look on the bottom axis at less than 6 grams per liter and take all of those samples to the left of that, that's the vast majority of samples, so in the high 80s%, were below 6 grams per liter using that cutoff. So that was certainly helpful for us to know that it was working. And then we found also that 56% of the samples were less than 4 grams per liter. So we thought we had something that we might be able to use to helpfully screen. The other thing that came out of the study, which was a little bit of a surprise to us, was that we found between 1% and 2% of the samples that were low also had this situation where they had a newly discovered small paraprotein which was knocking off or immunoporesing the rest of the production of antibody. We then looked at about 300,000 samples, took the low samples and asked, where do these come from? Which specialty can we link that to? And you can see in the middle that, perhaps not surprisingly, hematology, so hematological malignancies, but actually quite a few other specialties came up as well, such as primary care, general medicine, general surgery, rheumatology, neurology, nephrology, clinical oncology, and then some like anesthesia or cardiothoracic surgery, where that might more reflect some of those perturbations because of fluid that we talked about earlier. So then we increased the stringency and we said, well, what about if we looked at where do the samples that are only less than 4 grams per liter, so more than 2 standard deviations out from the lower limit of normal, where do they come from? Well, again, hematology was there, but what you can see straight away is that surgery, which is the one where maybe you'd expect the IV fluids to happen, was much, much, much diminished. So if you increase the stringency, you would tend to see hematology, oncology, primary care, nephrology, outpatients as well, general medicine. So still a real range of places that had low levels. We then focused just on hematology, and in fact, the 3 categories that we might be most familiar with in terms of associations with antibody deficiency, secondary antibody deficiency, CLL, myeloma, and lymphoma, particularly NHL, but also these other categories like acute lymphoblastic leukemia, CML, myelodysplastic syndrome, Waldenstrom's. So it's not just the 3 big ones, there are other ones tucked in there as well that were highlighted by the study. When we concentrated only on general practice, so primary care where you would not usually have intravenous fluids or surgery taking place, we had perhaps some very non-specific findings like tiredness, cough, bloating, and again, these are areas where it would be really nice to pick up the cause if the presentation was non-specific. Some, of course, that we recognize, CLL lymphoma and some particular medicines, methotrexate. And one thing popped up which caught us by surprise, which is clozapine, accounted for 13% of those samples, and that's a drug used in treatment-resistant schizophrenia, which I can touch on later as well. So new things coming out of the what is essentially a rather unbiased screening process. So here are 3 extremely good-looking gentlemen. Antonio Pecoraro on the left, Giuseppe Spadaro in the middle, and Antonio Condino Neto from Brazil, friends and colleagues who have also developed calculated globulin screening in their centers. And from the center in Naples in Italy, they undertook a validation process, found the cutoff that we had found was actually very, very close to the one in Wales, and they then went on to retrospectively look at their CVID cohort and ask the question, if we had been using calculated globulin, would we have picked up these cases perhaps even before they were actually formally sent in? And they were able to pick up the antibody deficiency in 97% of the cohort that had available calculated globulin results. So that was very reassuring to us. In a further progression of this, Antonio Condino Neto and Cristina Sartorelli in Sao Paulo have been looking at extending the study of calculated globulin from adults to children, which is, of course, really challenging because the reference range is different with each age. So they've, in essence, done multiple studies to look at this, and again, that looks very, very promising data. So I was going to just come on to a case now. This is a 19-year-old gentleman who was seen in clinic and had a history from very young, where his mum said he wouldn't stop dribbling, and she was told by the medical team that this was because his tongue was too big for his mouth. At 4 years, he had a tonsillectomy, then needed adenoidectomy as well. He had impaired hearing and had grommets inserted on 3 occasions, and then needed a hearing aid and developed a chronic cough from the age of 4 years. He had sinusitis and a postnasal drip. He had about 12 to 15 infections a year and lost up to 60 days from school per year. And in fact, at one stage, he was sent home because his cough was annoying the rest of the class. He tended to cough through the night, didn't sleep, and then fell asleep during his important GCSE exams. These are exams you take when you're about 16 in the UK. He had about 6 chest infections needing antibiotics in the year before we saw him, and 2 admissions with pneumonia. We asked him, when did you last feel well? And he said, never. Out of 10, 10 being best, 0 being terrible, how would you rate your health? 3 out of 10. We worked out he had about 180 visits to his GP in 15 years. And I'll talk you through his serial chest x-rays. He was tested for all sorts of things, HIV included, and then in 2012 was found to have absent antibodies. But I wanted just to show you very quickly his chest x-rays. So chest x-ray reports here are heart size is normal, no focal active lung lesion, lungs look a bit hyperinflated. And I'll just walk you through his x-ray reports over time. Next one, normal heart size, lungs are clear. Next one, patchy airspace changes noted at both bases, basal consolidation. Next one, the appearances may be due to a further bout of infection in the left lower lobe. However, chronic changes should now be considered. Suggest follow-up. Chest physician. Next x-ray. I also think that there are increased airways markings medially at the right base. The patient presumably has bronchiectasis. Has cystic fibrosis been excluded? So you can see that these x-ray reports over time are telling a rather sad story of the development of potentially chronic changes. And all the time, the calculated globulin value was low. So this little star here was present on that original report before the x-ray changes. And so if there had been the ability to highlight what this means, because I think when I even spoke to the biochemists, they said they weren't really sure how to use that number. So the answer was kind of there with a star next to it all those years ago. So what we did was, because I do think it's a good question, whether it is more difficult to think of the diagnosis of PID or indeed to make the diagnosis when you've thought of it. It's a slightly philosophical point, but you've got to have the light bulb moment to start doing the digging to get to the bottom of it. So we've inserted now in consultation with GPs this comment which appears electronically if the calculated globulin is low. So it doesn't need a person to enter it, it is automatic. And it just says, low calculated globulin may represent antibody deficiency. Consider checking immunoglobulins if there's a history of infections. And so this was in feedback from primary care, who said, we want to know what it means and we want to know what we do about it. I thought that was a fair comment. So now I would say low calculated globulin is the commonest reason for referral to our service, because they're being picked up across the whole of Wales. So I thought I'd talk to you just in the last minute or couple of minutes about patterns. And this is a difficult one. So if you look at this pattern, some people can see this more easily than others, and it's certainly nothing to do with intelligence. But if you look deeply into that pattern, you may be able to see two seahorses and a star just in the middle. And so the point I was trying to make is that sometimes it's about the pattern rather than the individual value. So I'll show you some patterns, because on the pathology system, when we're in clinic, if you click on the graph function for calculated globulin, we are able to see values going back for the entire time graphed that anyone has had liver function tests performed. So this is an example where, in fact, there is a low calculated globulin and that little dip down, but it's only one. Everything else looks normal. So I would look at that in clinic and say, well, actually, you know, that might have been flagged up, but to be honest, it's almost like an outlier. I'm not sure I have an explanation, but generally speaking, the level is normal. So here's someone who's been potentially referred to clinic with a low level, and you can look back historically across time and see that, in fact, this has been a gradual decline, and that, in fact, it looks like the trajectory for this individual is downward. So that's an important thing to know when you're assessing them. In this one here, it's another declining level, and I will tell you that this is actually a child from neonatal intensive care, and what we're watching is, in fact, the decline of maternal IgG. And so they were, in essence, consuming this and then had a problem with CMV, and in fact we ended up giving them immunoglobulin temporarily. Another declining levels, and I think from this one, this is, I believe, a rheumatology patient who may have required a number of rheumatological treatments, and you can see that where you have lots and lots and lots of dots, it means someone is either in hospital or being monitored very closely or being treated with something that needs monitoring. And you can see that over time, and maybe with some treatment being introduced, the levels have dropped. Here's another pattern when we look back of someone that has just always had borderline low levels. So needs obviously more assessment, perhaps in terms of immunoglobulin levels and functional assessment of vaccine responses. Persistently low levels. So when someone comes to you, you can immediately see that this is not a new finding. The history of low calculated globulin and likely low antibodies goes back for years. And so here's rising levels. So this is the exact opposite. So on the left here, you can see a very low level, and then it comes up, crosses the green line into the normal range and stays there. And in fact, what we've done there is replaced someone's antibodies, and that is their IgG level coming into the normal range. On the right-hand side, you can see the same thing with calculated globulin in the same patient. And it's not quite as beautiful as IgG, but you can still see the same pattern on being replaced. And this is someone who was referred with clozapine with a low level, and you can immediately see that, in fact, they've had low antibody levels for a long, long time and need further assessment. So just to wrap up, I wanted to present to you calculated globulin as a cheap, potentially free, if you're already doing total protein and albumin within your liver function test profile, extremely easy, unbiased, and as yet underused approach to screen for antibody deficiency. It will find primary antibody deficiency, and we have a lovely annual patients meeting where now we ask the question, who's been diagnosed by calculated globulin, and lots of hands go up in the room. It also finds secondary antibody deficiency and paraproteins, and it's now the main referral reason to the clinical service. It's possible to use it both in resource-rich and resource-poor settings, and it's even found a potentially novel cause of secondary antibody deficiency. I would say also it's been a really delightful cross-specialty collaboration with colleagues in biochemistry, and we've got new projects developing from this, and also across nations and international collaboration as well. And just to highlight those, obviously from Italy, Antonio Pecoraro and Pepe Spadaro; from Brazil, Antonio Candino Neto and Cristina Sartorelli; in South Africa, Johnny and Monica; and in Turkey, Asli Jelinek; and a growing group of members of the Calculated Globulin Club. We haven't actually got calculated globulin cufflinks for sale yet, but maybe one day. I thank you all for your attention.
Thank you very much, Professor Jolles, for presenting this interesting screening test that could help speed many diagnoses. But now we'll take some questions. We have a very busy attendance, I have to say, and very interesting questions. And I would like to invite Dr. Darn to join us on stage. Dr. Darn, are you there? Yes. The first block of question is about where could we use this method? Could calculated globulins mostly be beneficial in developing country context, or also developed in developed countries? And because we mentioned Brazil, Italy, we can also see South Africa. What would you say?
So I think if you were to talk to your colleagues in the biochemistry labs, which is usually where liver function tests are performed, if they have albumin and if they have total protein, calculated globulin, because that is just a calculation rather than a test. And so if you have those two things, you have for free the answer. So then you essentially, I think, would I would suggest it would be helpful to establish a lower limit of a normal range for your geographical setting, and certainly we'd be happy to link up on with anyone who wanted to know the methodologies we'd used, so that that could be duplicated locally, because you may have a slightly different value, but it's important to have a one that you can rely on locally. And I think for sure, if it's free, the resource richness of the setting is to some extent removed. You don't have to have huge resources. You can actually apply this on the many tests that might be done in primary care elsewhere as part of the standard of care already. And it does mean that the, let's say, general practitioner, they don't have to think of immune deficiency. It's really hard to think of immune deficiency when actually your main problems are to do with heart disease and hypertension and all sorts of other things. But the in silico will pop it up on your screen. Low calculated globulin may represent antibody deficiency if there's a history of infections, etc. So obviously you can devise a comment that's appropriate for your setting, but it's just that turning the light bulb on. And I think absolutely for resource rich or poor settings.
Yeah, and I think indeed, for developing countries, but also like you mentioned, that's also been one of the questions in the group. I think it's a strong tool for general practitioners and doctors in internal medicine who are not really familiar with this topic, but they have had already many measurements of albumin, total protein in patients' lives, so that they have already the test results, but they did not interpret these test results until now.
Exactly. Yeah.
Maybe a tricky question right now. Can we use it for neonatal screening, or will it count IgG level and would not be specific enough?
Sorry, I missed the first part of the question.
Can we use it, this test, in neonatal screening?
Okay. Yeah, no, that is a difficult question. So I would say that the pediatric use of calculated globulin is where Antonio Condino Neto and Christina will be the experts. They have done, I think now, well over 1,000, and they've broken it down into blocks of age, like, for example, 0 to 2, 2 to 4, 4 to 6, because the reference range changes in children and establishes a sort of close to normal or adult range, I should say, at about 9 or 10, but starts to get very close at around, above 6 years of age. So they looked at the correlation between calculated globulin and immunoglobulin in children and found that it did correlate, to my surprise, because I thought, actually, this is going to be really difficult in children. So it did correlate, and I think one does have to note the difference in reference range. So we are a little bit further advanced in getting established cutoff levels for adults, but Antonio and Christina are certainly working to see if there is a way in which we can establish appropriate age control cutoff levels in children. Obviously, in the neonatal setting, you are measuring maternal immunoglobulin, which is also potentially important to know. And sometimes when you're referred a child in a neonatal intensive care or in the pediatric setting, people may not have thought of measuring immunoglobulins as yet, but if they give me the name of the child and the hospital number, I can go into the pathology system and very quickly see the calculated globulin kind of as a snapshot to guide me, even if in the end we use it to prompt us to measure immunoglobulin so that we have the definitive levels there. But it's ongoing work, particularly in Sao Paulo, to try to look at the pediatric ranges. But yeah, it's a good question. Thank you.
Yeah, and more generally about the ranges, why is the reference range different in age groups outside children, I mean?
You mean in the adult setting in different places? Yeah, so I think in general, they will not be very different,
Okay.
but there are, of course, differences that exist in perhaps different nationalities, and certainly in South Africa, I think they had a slightly different range that they were looking at. And I think it's always important that you have a local, locally established reference range that is based on your results, on your biochemistry instruments, because it's a calculation based on what will take place in biochem. So I think there are a number of factors that make it helpful to, usually with something called ROC curve analysis, to make a cutoff that is most appropriate for your setting. And so we set it at 18. I think the one in Naples turned out to be 19. So they weren't very different. And you can move it up and down depending on how you want to tweak your sensitivity and specificity, so that you could be, some colleagues in Birmingham actually set it lower than 18, which meant they got less positives, but wanted to see the more severe lower end calculated globulin. So in a sense, that made it more likely to pick up lower levels, but it might miss some that were still low. So it's that balance that I think is helpful to establish locally, and it also builds a relationship with the biochemistry colleagues, because I think certainly ours have been really interested in this project, and are now, they've bought in as delightful collaborators.
Mm-hmm. We have more specific questions. For example, if CVID is not evident at birth, when does it manifest, and might CVID actually be there and not be detectable?
Yeah, that's a good question. So some of the answers to that we don't know, but we know that CVID can appear really at any age. So you can get CVID if you were 79 years old or 40 or 30. It's more difficult to diagnose under the age of 4 because of the difficulty separating it from something called physiological hypogammaglobulinemia of infancy. But if we're thinking of the adult setting, then the hypothesis might be that you have a genetic predisposition, and we understand some of these, but not all of them. And in fact, I'd say we probably don't understand most of them at the moment for CVID. And then maybe a second hit occurs and antibody levels decline, and the diagnosis is then made usually several years later. So the calculated globulin screening, when you look back at a known set of patients who have a diagnosis of CVID, you can sometimes actually see the point at which the levels start to fall, and that they decline over perhaps about a year. And so it's a gradual process. But I think in terms of the question, it is quite possible to have someone who may have a genetic predisposition, but still has normal antibodies, and then later in life develops CVID. I think there's still a lot to be learned, but with liver function tests, if people are going in for other reasons and a GP is undertaking a, like a screening set of bloods, a full blood count and LFTs and U's and E's, in amongst that, you will get the calculated globulin. And if that is low, it may just give you that clue that's needed to think of immune deficiency.
Maybe I would like to take maybe a last question. Is it possible to start a calculated globulin screening without a local validation study?
Well, I think it's possible because there are the cutoffs which are in the literature now. So you could take a look using those cutoffs and you know, almost do a evaluation of what, using a cutoff of, let's say, 18 grams per liter for a methodology in biochemistry called bromocresol green. There's another methodology called, long name, bromocresol purple, which has a cutoff of 23. So it's really helpful to know what your biochem lab is using to then choose your method-specific cutoff and do an evaluation. And it may be that that is, you know, very near where you need to be. But I think for the finer detail, it's always nice just to look at a number of samples around the, you know, predicted cutoff, because we now know where to look roughly, and see if that fits for your service and your geography and the biochem instruments and the setting, so that you've got as good a cutoff as possible locally.
So thank you so much. Now we come to the end of this webinar, which was made possible thanks to a kind donation from CSL Behring. On behalf of IPOPI, I would like also to say a big thank you to Professor Jolles and this enlightening presentation and for the answer you provided. We also thank Dr. Dan for your contribution, and for the questions that remain, don't worry, they will answer them by written. Thanks again to all of you for attending this IPOPI webinar. If you have a minute to spare, we encourage you to share your feedback at this webinar by pressing the link shared on the screen right now. And this link will also be posted on the chat. Please note that you will be able to see the recording of IPOPI TV on IPOPI TV within a couple of days, and we encourage you to share it as much as possible to those who you think will benefit from it. Please take care, keep safe, and thank you for being there with us. Bye.
Bye, everyone.
Bye-bye.